Hello and welcome to Long COVID Foundation podcast. This is the channel where we share educational information on long COVID to help you understand your symptoms better. In just a moment, we'll have an interview on neurology issues during long COVID with Dr. Abdul Mannan Baig, Assistant Professor at the Aga Khan University. Dr. Abdul has been involved in numerous publications around neurology and long COVID, and we wanted to bring his expertise to our channel to learn more. We had numerous questions from our Facebook group members on this topic, and I would advise to watch this video from start to finish because it will help you to learn more. If you are new to the channel, make sure you hit subscribe button because I can help you to get answers relevant to your symptoms. Now, let's jump into our interview. Hello and welcome to Long COVID Foundation channel. It's my pleasure to introduce you Dr. Abdul Mannan Baig, who is an active clinician and basic scientist in COVID and long COVID. His research has contributed to the recognition of loss in smell and taste in COVID that he hinted at back in March 2020, including proposal of virus using the nose to access the brain. Dr. Baig is recipient of National Award of Distinguished Scientist by Pakistan Scientific Society and is recipient of the Most Productive Researcher at Aga Khan University. It's such a great honor to have you on our channel.
My pleasure. Okay, good afternoon and welcome to all of my audience here.
We have significant issues related to post-COVID neurology. So many people report autonomic nervous system dysfunction, heart rate elevations with mild exertion, tinnitus, dysautonomy issues, headaches, burning needle pains in hands and head, issues with eyes and hearing. I would love to hear your views on what are the main causes that for these symptoms and how virus progresses from being mild at first and then to the development of severe neurological issues. So I would love to understand more from this perspective, and if you could share what you've learned so far in this area.
So this is my first slide. Okay, so let's start with this one, and this we would like the audience and the viewers to know that WHO has formally recognized long COVID as a disease now. I was one of those guys, okay, who were fighting for giving it a name in very beginning of October 2020, where I advocated that it should have a proper terminology so that, and recognition by WHO and CDC, so that we can first officially document it as a disease and then start research over it. Now, this agreed definition says that this condition starts after the acute phase of COVID and usually within 3 months from the onset of the symptoms. And they have set a line that it should last for at least 2 months and it cannot be explained by some other diagnosis. Common symptoms, if I'm not wrong, this is only a summary of it, which includes fatigue, shortness of breath, cognitive dysfunction, and lots of list of other symptoms which is missing here, but they have just concisely tried to put it here. Symptoms, they say, may be new in onset following the initial recovery, or it could persist from the initial illness. And they say that symptoms can fluctuate or relapse over a period of time. Now, the definition seems to be a very naive and an initial one, which is nothing wrong with it. At least the recognition that it is a disease, okay, is a big thing for the community and the long haulers and the long COVID. The patients have been fighting for this for so long. And as we speak, even in this first month of 2020, they find very little, if any, on the treatment part of it. And let me tell you, though this is the first slide, but it's very worthy to say here that we are still in the infancy of discovering the pathogenesis and the factors underlying the complex presentation in long COVID. Now, the other slide we show you here is that that was our contribution in October 2020. Now, it's almost, you can see it, 2 years now that when this disease was first recognized by the patients and patient advocacy groups were actually trying to make the scientific community understand at that time. This is a time in publication where only 6 papers were published on long COVID, and most of them were called as long hauler disease at that time. Nothing wrong with it. Okay, patient can have their own choice of naming a disease when they are in such a high number like 1.43, 1.6 billion now in UK alone. So my thought here was that in order to make the governing body and policy forming institute to recognize the disease, to introduce the term syndrome here. Okay. Now I will take 1 minute, okay, to explain it so that audience can understand. There is nothing like I want to replace the long hauler term introduced by the patient advocacy groups. But you see, in order to reinforce your point, okay, and make it look like a disease and make the officials and healthcare governing bodies to understand that it's a disease, in medical science, we use the term syndrome. The syndrome means a complex combination of sign and symptoms. Signs, what you see in the patient; symptoms, the patient who comes and describes something to you which you cannot see. You have to believe that what the patient is saying is he or she is suffering from that condition is known as symptom. Now, when you combine signs, which you can see in the patient, with what the patient is complaining, okay, the complex is known as syndrome. So if you hear any conditions in medical science with the term like syndrome, Mallory West syndrome, or you can name list of the conditions, okay, which come with the term syndrome. They should have some things that you see in the patient and some things which the patient described. So chronic COVID syndrome was the term which we proposed here, and we debated it, and we wanted not the term to be recognized as a syndrome, but more the disease to be recognized as a disease in the first place. So luckily it happened, okay, and you see things like 3 weeks, 3 months that we put into this paper was picked up by WHO and CDC, and they tried to actually come up with a logic that which we debated that in case of some diseases, we give an example like liver disease, anything that is beyond 3 months is considered chronic hepatitis. So we put a dividing line that if 3 months or 2 months can be agreed, okay, we can then define long COVID or long hauler as a disease being continuous for three months in a row after the initial onset of the disease. So this paper shows our fight from the very first day. And I told you minutes ago that at this time we only had 6 papers on long haulers in the PubMed. Now they are over into 6 digits, okay, if you see. But this was October 2020 when we actually advocated for the disease itself. Now, the next point is the topic for which many of our viewers are very awaiting to come see some comments over it. Now, if you list the disease sign and symptoms in long COVID, and suppose for the sake of argument, okay, let's say they are 100 in number or 55 in number, you'll be surprised to see that 60% to 70% of those symptoms are peculiarly the ones which can be related to the brain or the central nervous system. Like you said, dysautonomia in the beginning and several other things, okay, which the patient referred to. You when you take it back, okay, it could be very easily referred to the central nervous system or a subpart of it. Now, if you see this one, brain fog, dizziness, inability to concentrate, even shortness of breath, okay, all of which we called it a Neuro Covid. And when we say Neuro Covid, we don't mean only acute COVID. We also include the long COVID in it. So we hypothesized initially, and this is a image from a published paper, that there is a type of a damage to the neuron. Now, the $1,000,000 question, when I say damage to the neuron, what type of damage? How much of it? How much of it in the sense that the patient is exhibiting symptoms and signs related to it? So we postulated that the mechanisms are more than one. There could be a direct effect of the viral insult on the neuron. That means the virus is neurotropic. It can cause selective damage to the neuron. It could incite inflammation in the brain. The inflammation produces cytokine, and that cytokine then actually affects the function of the neuron by causing damage. So if you can see the mouse moving, number one is showing the effect of the virus on the neuron here in the white circle. Then we amplify it on the right side to show three figures. Number one, the virus affecting the neuron directly, B1. This is a type of a damage in which the virus makes it sure that it kills the neuron. And there are over 2,000 papers on the neurological deficits caused by the virus alone. Then comes the B2 figure, so in which you see vascular effects or inflammation being written with some red lines showing that blood vessels are dilated and cytokines are being produced. What we postulated that there are two types of neurological deficits in patients with long COVID. The ones which are reversible, the ones which I and my colleague think that are not easily reversible. So if there is a damage caused by the virus, as you can see in B1, this is not reversible because neurons do not divide and compensate for the loss. So B1 is a loss forever. B2 is damage going on, which can be reverted by anti-inflammatory drugs or a cytokines antagonist. So there is a chance of recovery, as you can see an arrow going from B2 downwards, that reversibility or some damage prevention is possible. Now, this is what is happening in patients with long COVID. If they are exhibiting some sign and symptoms, which shows paralysis of some function of a body organ, tissue, or a muscle, okay, which is under the control of the central nervous system, that most possibly could be due to a direct damage caused by virus. If it's a symptom, and you know it well when I speak, okay, many of your patients say that for a day or two I feel good, and then I again start feeling bad, the same symptoms revert. So my question is that why this is fluctuating? So if the inflammation is going on very at its peak, okay, the symptoms would be there. And then they take medication, or the body owns the ability to reduce the inflammation, goes and takes over it. Okay, some inflammation subsides, patient starts feeling better. So whatever you are seeing on the slide now actually is what's happening inside the brains and the central nervous system of patients with long COVID. So in a moment, we'll talk about this brain fog and dizziness and inability to concentrate. Is there a chance that they would revert back? Is there a chance that the patient would become better? That all depends upon, honestly, and I won't want to fabricate any thoughts here that if the neuron is killed, okay, in time it's going to be replenished. No, it doesn't happen. If the neuron is dead, okay, it's dead forever, except for very rare stem cell therapy replacement, very precise replacement by stem cell, you can regain that neuron function back. But your body has got no capability to actually cause cell division of the neuron, because neurons are permanent cells. Once dead, they are replaced by glial scar tissue. They don't actually are compensated by the regeneration of the neuron itself. So B1 is a damage forever. B2 is a damage ongoing, which can be prevented by anti-inflammatory drugs. And you ask me why patients with COVID, okay, admitted to hospital get benefited by corticosteroids. That corticosteroid is an anti-inflammatory drug. It suppresses the inflammation and the immunity and stops the ongoing inflammation. The reason the patients do recover, whether it's lung or brain. So B2, good news, okay? Because B2 can be managed. So the future is not bleak for the patients with long COVID. We just have to understand it's a new disease. So it takes time to understand what actually the virus is eliciting. Its mechanism of damage production is not one. It is acting in concert. It wants to confuse us so that we don't understand how it is actually damaging the systems and the body. And the reason you see a long list of complaints in patients with long COVID. Not all of them are due to neuronal injury. We take you to the next slide, where we show you that if these problems do occur, and we actually, this is another figure from the same paper, we projected that if visual problems, inability to concentrate, short-term memory loss, or even shortness of breath, loss of voluntary control over the breathing process, if they continue, it's going to result in disability. So this is October 2020. Just imagine, we are sitting here January 2022. Now, the wheelchair that you see on the left-hand side, the hospitals and homes are filled with it. I know people who cannot leave their bed or their wheelchair for weeks in a row. So the prediction was that if you don't treat it, if you don't recognize the disease, if you don't give the attention now, it's going to paralyze and produce disability, and the cost of which is going to overwhelm the healthcare system, which is already being ruined by acute COVID patients. So as we speak, now you see the money is coming out, 1.3 trillion US dollar by NIH alone, NHS investing same amount for long COVID. Why? Because I would honestly say that we got a little late, okay, here. But late should not be worse, and we should not slow down, because the virus is not slowing down. Because if we don't keep ahead of a curve with this virus, it's going to cause disability. It has proven it. Okay, so there should be a very little doubt in the thought process of the policymakers and governments that yeah, forget about it. It's mild. It's a common cold, so it will come each winter and just taste your lungs and your respiratory tract, give you some tissues with nose to blow, and then it will go off. No, this virus means business. I mean, like it is not a conventional, what you call as virus that is going to just go away over a period of time. Each winter it will come, it will cause disability, it will cause productive, daily working, hard working, diligent human beings to go into bed, for ages. And just imagine the burden it is going to cause on individual level and on national level and international level. So at the top, the red arrows you see, I made them red because of a reason. They are ominous. They are red as an ambulance and a fire brigade. I predicted that it's going to cause neuro COVID disability. It doesn't seize ethnicity, religion, color of the skin. It's actually causing disease to each and every sector of the population that we know. So other things which are listed below are not neuro COVID, like myocarditis, palpitation, gastrointestinal, skin rashes, urinary bladder control, easy fatigue. All of these are non-neurological, but just see that how the virus can produce 60% of its symptoms related to the brain. To the question that how and why our body actually harbors this virus, okay, to take it to long COVID and neuro COVID, okay, over a period of time. The next slides will tell, but the initial slides I managed to put there so that we can address the enormity of the situation, that how serious this issue is. Now, just below the long COVID, okay, see a residual virus written here. I've managed to show a person who's in nasal cavity has got the virus, and then this virus from here goes to the brain and causes brain, what you call as damages by inflammation as well as direct viral induced cytotoxicity. The thing is, the virus is clever. It knows to go to places of the WBCs and the lymphocyte, and the antibodies cannot detect it. So there are some places in the human body which I call as immune evasive sites, where the virus can rest, but the immunity cannot detect it. When a person gets an initial infection, the virus starts planning from day one that a sub quantity of my population will go to the lung, others will go to the liver, brain, GIT, okay? And some of us are going to hide at the upper part of the nasal cavity. We have got cheekbones here known as sinuses. In the middle of the sinus, no WBC, no antibody can go there. It goes, hides there. It has got places in the eye where it can hide. It has got places in the body, okay, where there are pouches and sacs, okay, where it can go and reside there, okay. So if what happens is that me or you suffer acute COVID, our immunity prepares antibodies and T killer cells in 14 days. And those T killer cells and antibodies cannot completely remove the virus. Let me say it slow. Cannot completely remove the virus. The virus will stay. That virus I call as residual virus. That's the teaser. So when the 22 days are over, it's going to again send a small subpopulation into the circulation, teasing the immune system again, immune system responding again, you getting symptoms, again you back to bed. So this is what the long haulers and the long COVID patients are complaining. They say we feel a bit better, and then there is a reinfection, or they exactly don't know it's a reinfection, but then they know that what they suffered in the initial phases, it looks like that. They say in a layman term, I feel sick again, just like previously, but this time I've got my eye blinking as well. Additional features appearing. Why these additional features are appearing? Because the next time the immunity responds, okay, it responds very aggressively. So the disease next time is not going to be mild, okay, be it long COVID. When we say long or chronic COVID, there are some papers and even some policymakers these days make it look like long COVID means, subtle, it's a bit humble now. No. Don't get it wrong. Okay, this virus is no humble at any stage of its infection. So in long COVID, when it causes other episodes, okay, those episodes flare up the patient and the patient doesn't likes it. But then I'll tell you, physician doesn't likes it. When you go describe it to him, okay, he or him thinks that this is a post-viral depression, or anxiety, the guy is feeling overwhelmed, okay, due to the routine. No guy is going to just come over and complain without a reason that he has got an inflamed vein. Okay, I know guys on my Twitter followers, okay, they have got bulging veins over their chest and the hands. And when I say to them, okay, how much it's bulging, they show me and then send me the images. Okay, I'm scared. Bloody, this never happened in the acute state. Okay, so why is it happening now? It's the residual virus. Okay, it's teasing the immunity again and again. So if we fail to eradicate the virus from the residual areas, there will be a problem. The virus will stay and it's going to cause the problem. Now, the not the million, but the billion-dollar question is how to eradicate it. Okay, we'll come to that in a minute. But then the million-dollar question is already stuck. That what can we do about the residual virus? If we can kick it bad, if we can just remove it from the areas where it is residing and playing tricks with us, we will succeed to lower the percentage cases of long COVID and long haulers. So when the virus is a residual one, you sign off, okay, now it's a disease which will become long COVID. And the diagram that you see here, where man is being shown with virus going to the nose, I've tried to incorporate other concepts like coagulopathy, okay, microclots, and other theories that are very popular in patients with COVID. But my question is, even the microclots, okay, being formed is due to continuous arrival of the virus again and again in the circulation, stimulating the platelet, okay, stimulating the prothrombin pathways and the clotting pathways. Why this virus is coming again and again if our body was successful to eradicate in the first place? It's the residual virus. It hides. It comes back again and it teases the immune system again. You tease it again and again, the clotting pathways are going to get activated, small thrombi will be formed. And once the thrombi are formed, you just name it. Any organ or a tissue, blood flow goes reduced, the patient will complain. What else would a person do? Try a rubber band, okay, over your finger for half an hour and then tell me that what happens at your fingertip. You'll complain. There's a congestion there. The finger becomes blue. You start feeling the ache. So what the rubber band does? Reduces the blood flow to the finger. What the microthrombi does? Reduces the blood flow to any part where it actually goes and blocks. If complete blockage, it could cause a complete death known as infarction. We call it tissue death. But if the microthrombi are just reducing the blood flow to 60 or 50%, guy is going to complain. Okay, why you ask a patient with long hauler that why you have got a list of 55 complaints? Okay, you seem to be psychogenic. So what would I do if I am having 55 organ complaints? Okay, I would complain. I mean, like, you can't duct tape me, okay, and say that okay, just filter them and give me only 16 top complaints of those 55. Not possible. Please try to understand the patient's situation. They are in immense distress. They are frustrated. So microthrombi, yes, they are there. Okay, the virus is in the blood vessel. It also causes inflammation, but the prime responsibility is to remove the residual virus by one way or the other. So we will have to find the way to actually eliminate the residual virus from body cavities. My active area of research is this one. I'm these days working on how to remove the residual virus, okay, therapeutics as well as pathogenesis, so that in time we can reduce the residual virus. Once the residual, don't blame the immunity. Immunity is like it's like a mirror. You don't come in front of it, okay, you will see no face. But if you come in front of it, okay, you will see a face. That face will be yours. If the virus doesn't shows up, the mirror will not show any image. Immunity responds. Immunity is not to just sit there and make faces by itself. So if we remove the residual virus doesn't come in front of the mirror, okay? The mirror is not going to respond by showing us image. So my active area of research says if we remove the residual virus, we will win over the long COVID, okay? So let's see what happens in time, okay? We'll keep you posted on that. Now, this was one of the questions of your group members and your community, that dysautonomia is a part of the neurological problem. My pleasure to answer it, okay, because it creates much confusion that whether this should be incorporated as a part of neurological finding or not. First of all, let me make it clear that autonomic nervous system is a subclass of central nervous system. It's called as autonomic because it's not under our control. Like if I ask you, okay, that what was your heart rate in the last minute? Okay, you can't say exact figure. Why? Because you don't have a control over its regulation and its generation. How many times did you breathe in the last minute? Okay, you were breathing. Okay, it might be 18 or 22, but you don't know the precise figure. But if I ask you how many fingers in your left hand, you can touch them, see them, and say 5, because this is something under conscious control. Autonomic nervous system is under subconscious control. And when the virus affects the brain, it has got no distinction to affect only the conscious center and spare the autonomic center. It attacks the autonomic center as well. So the viral traces and mRNA traces of SARS-CoV-2 have been found in medulla oblongata, brain, midbrain, and even hypothalamus, which shows that it has got no mercy for these areas as well. So if an inflammation is ongoing there, or it has caused some neurological damage, instability of the heart rate, instability of mechanism like sweating, you stand up, the blood pools down, you have got a defense normally. Body causes vasoconstriction and doesn't allow it to pool. But if your nerves cannot cause the vasoconstriction, you stand up, you are going to get a dizziness. You will get a tendency to fall because autonomic nervous system is not functioning at its optimal in patients with long COVID. So the reason you see dysautonomia is a part of a neurological problem is truly the affection of SARS-CoV-2. As you can see here, I've shown the virus affecting the midbrain, the pons, and you can see in even medulla oblongata, these areas. And if it is affecting these areas, the output will be affected, and you will have problem with all of the autonomic features. I know some of my followers, okay, who have got one pupil dilated, the other pupil normal, it doesn't reacts to light. What's this happening? They all had acute episodes of COVID, and now they have got residual virus that's playing with their brains and their autonomic nervous system. Stabilities of POTS and other conditions would be there. So it's only we have to recognize that it's a neurological problem truly related to COVID and its residual effects. So yes, dysautonomia is a part of neurological problem. It affects parasympathetic nervous system as shown here. It also affects the sympathetic nervous system shown here. If you go check those blogs of these long haulers, they say, I don't know, my heart rate, I just stand up, okay, it becomes 120, 23, sitting 70, So why is this happening? This instability, it reflects a true involvement of the autonomic nervous system in patients with long COVID. We will have to address it. As much as we hide from it, that it will become okay with some green tea and some cups of coffee and some honey and some black pepper. It's not happening. You can't eradicate a residual virus with the black pepper or honey and coffee, So we have to face the reality. We have to locate those sites where the virus is hiding, or make our immunity capable of reaching those sites, okay, so that the virus gets eradicated. You had a next question of Reen syndrome. This one was particularly, I made this slide so that your readers can know that there is a sensitivity to light, especially sunlight and some particular wavelength lights. When they fall onto the eye of the patient cannot concentrate or sees some of the alphabets and the words hazy, the other become sharp. These type of features have also been reported. Kids are complaining that writing in their books are appearing funny, some of them enlarged and some of them go like miniature, and then when the teacher opens the light for a while, the eyes are watery. And this again is purely a autonomic function. My eye to produce a tear or not in presence of a suitable amount of light with a particular wavelength is actually decided by my autonomic nervous system. So though this disease is named separately, but it's a part and the parcel of autonomic nervous system. So even ophthalmologists are now getting to realize that this is a reality in cases of long COVID, and it's happening. Sometimes it induces headaches, okay, with nausea, and eye pains are being complained. So yes, the disease is there and it is causing the problem for a particular wavelength. So if you recognize one of your child, okay, is sensitive to that, just see to it, okay, that what wavelength of light or which light he or she is comfortable with. Don't put those type of lights in the room that can, when you switch them off, okay, can upset the mood of the kid, okay, or his ability to perceive vision in a clearer way. Question from you, okay, that insomnia, okay, a part of neuro symptom. Now, it's interesting, and I like it when these type of questions do come, because not all of the patients suffering these conditions are medical experts, so they would sometimes like to think that whether taking melatonin or other sleeping pills in long COVID, would it fix my sleeping disorder? And if I'm having it, does it mean that my brain is affected? Again, brain has got a center, which is shown here in red color, okay, at the bottom of the slide. This area is known as a reticular formation. So it has got neurons there, which keeps us awake. So like me and you awake now, okay, I'm giving this interview, you asking questions. The system is awake, and we call it reticular activating system. It actually goes like many a million axons, okay, sprouting out from this red area and keeping our cortexes awakened. When that neurotransmitter which it produces causes there is a depletion of its production, what happens that the person starts feeling a bit dizzy and we go to sleep. Now just imagine, like in the previous slides you saw that SARS-CoV-2 is capable of inducing inflammation. If it induces inflammation in this red bar, okay, where the virus I have shown, the cytokines or the inflammatory mediators are going to keep on kicking on the neurons and never allow them to get depleted of the neurotransmitter. So if the discharge goes on continuously, my brain would be like awake 24/7. And even if I try with 7 pillows, cannot sleep. It's not the pillow that makes you sleep or the light turn off. It's your brains which switches off very swiftly, okay, so that you go to sleep. So the reticular formation, the SARS-CoV infection, as has been established by some studies, that they have found the virus in the medulla oblongata as well. If it's teasing your neurons there in the red zone, that neurons keep on firing, okay, and they don't allow you to go to sleep. So yes, the sleeping problem is a neuro component. It should be addressed. The specialist in this field should know that how and which drug should be given, prescribed very safely to these patients, so that it may not interfere with their normal physiological function. Like, I'm going to caution some of my viewers here not to use melatonin in excess, because melatonin sometimes in the day, okay, it makes your brain feel like it has gone night, and then you will confuse between two situations, okay, and feel very much agitated. So amount used should be very, very carefully calculated. Takes us to the $1 million question, okay, and I put this one only because of the curiosity of the patient, that why only some fractions of the patient go into long COVID? Because if it's the residual virus, and residual virus actually causes the teasing of the immune system again and again, why doesn't it does that to all of us? Why is it doing to only a small fraction of the patients, okay, who are going into long COVID? Here I need you to focus more than any other slide that you have focused till now, only because you are about to understand the more complex question, answer to a very complex question, that why only small people, fraction of a people develop long COVID. Now you understand, I put it in a metaphor, okay, so that you can understand. See, our faces are different. Our choices of perfumes and coffee is different. Our choices for a breakfast is different. Our immune systems are different. Try to understand. I'm not going to respond to COVID in a way, my immunity is not going to respond in a way that yours. We have different genetic makeups. We respond differentially to a fixed dose of a virus. Very important, okay? I'm saying it very slow so that you can understand. Even if the dose of the virus is fixed, our immunity responds with a different magnitude. You have heard people saying that that will make your immunity strong. The stronger immunity you have, you can fight the virus. I'm a person, okay, who has been like trying to educate guys that, for God's sake, okay, don't wish for a very heightened immune response, because if your immune response is heightened, okay, with acute COVID, you are dead on the 7th day. Because the more your immune response responds, and it tackles with the virus, okay, in an enthusiastic way that amplifies the inflammation, your lungs are going to be on fire, okay, and you will need a respirator on the 5th day, and you're dead on the 11th day. So having a moderate immune response that can eradicate the virus is what is ideal. So you hear of guys, okay, who get COVID, get hospitalized, or they remain in the home, isolated, recovered very well, no persistence of the symptoms, no new symptoms. Ask me that $1 million question, which is written on the top. Why it happens in them, only because their immune system was not very low responding, not very heightened in responding. It was moderate. It's just eradicated the virus, did the job back to normal. So in what happens in long COVID? Now, because of different genetic makeup, what happens? Sometimes the virus dose is good. Your immunity doesn't respond like even moderate. It just responds a little, okay, and it doesn't clears the virus. Now, in this case, the virus doesn't even needs a residual, what you call a site. It's there, and your immunity was not enough to eradicate it. So it will be there. It will keep on teasing the immunity again and again, and you will keep on developing symptoms. I'm sitting here, okay, we'll sit here again after a year or 6 months, okay, we'll see the published paper then, and I'm going to just show you that they now know by data that a reduced immune response, which is incapable of completely clearing the virus, is the thing which is the causal factor in long COVID. So you see this slide, this possibly is the last one, okay, in which I published this thought, okay, in ACS Chemical Neuroscience ages ago. When I say ages, I mean like it was approximately 2 years back when I proposed this line. If you can just like go to where it's written, turn symptomatic. See the star? Turn symptomatic, then symptomatic COVID-19 depends upon 4 factors: persistence of the viral load, immune cell deficiency, evasion of immune response, and HLA class 1 and class 2 antigen. Now, this HLA is very important. That makes my immune phase and your immune phase different. So if we have got a different HLA class 1, class 2 antigen, some of them will respond very good. Some of them will respond not at all, low response. So a particular class of HLA, which determines our immune response, actually is the one that takes us to the long COVID. Can you see the arrow from HLA class 1 and class 2 coming down? And it says chronic COVID syndrome long hauler. Can you see this? Why this arrow is coming from HLA class 1 and class 2? Only because HLA class 1 and class 2 determines your immune response. So if you are genetically programmed not to respond completely to eradicate the virus will persist and the disease will go on. Doesn't matter if the virus is hiding in the residual area or not. Sometimes it will be in your body. It's your immunity that didn't clear it, and then you go into a long haul and see. Even before the WHO decided it in October 2021, we wrote there beyond 3 to 8 weeks. Can you see that on the left-hand side of the star? So 8 weeks, 2 months, isn't it? So after 2 months, the person shows persistence of the sign and symptoms of COVID. We at that time thought that it's appropriate to call those guys as to be as a long hauler. To the listeners, okay, my peers particularly who want to investigate this, if you have got a patient or cohort with long COVID, try to get their HLA antigen done and see what type of HLA class 1 and class 2 antigen they have got. If you have got 5 or 10 patients, okay, who completely recovered, never went into long hauler, get their HLA done. And then you can compare the HLA antigen of the persons who never went into long hauler and the ones who went into long hauler. You will have data, okay, even before anybody else publishes, and we'll be pioneering the research in long COVID, of which I offer you to be a part of, okay, if you want any insights on that, okay, any group from any country, any ethnic origin, speaking any language, you just feel welcome to contact me on the HLA subtypes leading to long hauler and long COVID. I think this is the last slide. Okay, so we have had few more last minute questions coming to me, and said that if the brain swellings have got, coverings have got swelling over it, okay, and lymphatics is blocked, okay, due to COVID protein invading the spinal fluid, can it be a cause? Now, this is a good question, because it's sometime the immunity which actually interacts with an antibody, the antigen antibody reaction actually causes the inflammation to progress. And sometimes the viral protein itself is capable of exciting inflammation. Now, if that is the case with the S protein, of SARS-CoV-2, that protein alone, even in the absence of an immune response, can go and cause affection of the coverings of the brain known as meninges. And if they are inflamed, they get swelled up. And everybody knows that when the meninges, the layers that cover the brain get inflamed, you feel fever, you feel muscle tightness, You have got sign and symptoms of meningitis, which even in the absence of an immune response can be one of the causal factors. So yes, it is possible. Okay, some of the patients, number two, have burning needle pain, and especially after vaccination, gets worse after COVID. A diagnosis of often small fiber neuropathy. What helps? So the last part is difficult to answer. What helps, but the initial lines, okay, which say that there is a tingling type of a pain. The thing is, COVID drives your metabolism very fast. When you have got an infection, okay, your body is in a state of hypermetabolic state. It's metabolizing everything. It's very common for vitamin deficiencies to develop in these phases. So yeah, it is possible that it may be the virus, but it could also make you run out of the vitamins. Okay, the reason you might feel burning or tingling pain in hands and feet. Small fiber neuropathy could be a part of coagulopathy or microclots. So yes, after the removal of the microclots, okay, some of the patients do feel better, okay, with fiber neuropathy, and this anti-clotting mechanisms, okay, nowadays prescribed in long COVID might help. Number three is it common for the base of your head to hurt where the brainstem is located and affecting eyes and hearing? Now, see, I can refer a pain to my head, yeah, but I cannot localize my brainstem. Okay, so if somebody says that my brainstem is hurting, it's just a way of them to express a thought. You cannot especially refer to a brainstem, but then the feeling is very vague. So yeah, one can have a headache, okay, because of inflammation of the meninges covering the brain, but it's very difficult or to impossible to feel the pain in the brainstem. Eyes and hearing, you just heard me. We have got a paper published on hearing and vertigo and tinnitus. Eyes, you heard me, are the potential site where the virus can hide and then get into the systemic circulation from time to time. Yeah, it's possible. Number four is numbness in the hand and feet due to neuro issues and how it can be treated. See, numbness is, again, I told you, is a neuropathy. So the microclots, okay, causing obstruction of the blood flow to the nerve can cause a neuropathy, and that neuropathy can very definitely lead to numbness in hands and feet. So if we can in any way correct that cause of neuropathy, okay, these issues are expected to settle down over a period of time. Okay, fifth one is who can help with diagnosing and treating autonomic nervous system dysfunction? Now, this is a good question. Autonomic nervous dysfunction doesn't has a particularly a specialist consultant who actually advises you on autonomic nervous system. It's a general practitioner, okay, who knows that some of the functions of your body are not under voluntary control. So if you are suffering autonomic instability, okay, he can actually direct that which of your complaints are related to autonomic nervous system and which are not. And then the basic thing is again back to the square one, that you fix the problem of the immune response against the SARS-CoV-2. You eradicate the residual virus, the autonomic, what you call as inflammation, would subside, and over a period of time, there's a good chance that you are going to regain those functions back. If you have one last line, okay, before we put an end to the last slide. As far as neurological function, remember one thing: if you have already not lost it, okay, it's very unlikely that you will lose it. Okay, now you have to ponder over this line, what I said. If you have not yet lost it, it's very unlikely that you are going to lose it. So be optimistic that whatever functions you are left with, okay, it's only a matter of time that we have to dig out the etiology of it, and we'll fix it. If it had to go dead, the neuron had to die, it must have been dead in the first 15 days of the viral infection. Okay, if it's not done, then the chances are very less that it's going to do it now. So it could be microclots, it could be inflammation, it could be cytokine behind it. Once we eradicate it, okay, you are going to feel better, okay, just like take my word on it. It's only a matter of time that we sort this out, that what's causing it, and then you are back to your life, okay, very wishfully. I should say that. Okay. Thank you very much, and thanks for listening, and for the Long COVID Foundation to invite me for this talk. I wish that whatever has been delivered here helps you understand your own disease, and with collaboration of this foundation, okay, I'm thinking of launching some projects, okay, which practically would help patients with long COVID and long haul. Thank you very much.
Thank you so much. That was a very informative discussion. There is a huge amount of information that is really valuable, because we up until today we looked into different symptoms of people, and we tried to locate the main cause, because we clearly understand that you cannot treat symptoms and without knowing what is the real cause of these symptoms.
Very
and
right.
The slides that you have put describing neurological symptoms, and in particular neuro damage that is happening post-COVID, I think it's one of the main reasons for all the symptoms that people experience for months. Now, the huge problem that needs to be addressed, I think, in this case, is to properly identifying this damage. As you said, you have to find these neurons. And I think this is something that our healthcare systems need to invest in order to allow people to go through this test, because this is quite costly, I would imagine, diagnostic solution. Yeah. But it's good to know it is possible to find it. So I think we would need to work more on the brain and neurological damage that is happening, and invest our time into researching what is causing and how to identify it in a more widely acceptable way, because people need to have access to these diagnostics. And
then when you were just saying those words, because you can't just put a stop to your brain. Okay, I was thinking that how is it possible? Valentina, there is a way known as functional MRI. You set up a person, okay, and you just ask him to perform different tasks and functions. And when he or she does that, a special area of the brain gets lightened up, okay, because it uptakes the glucose. Okay, we call it functional MRI. So if these patients, okay, who are suffering a specific neurological function, like you said, we want to know the exact area or the place where actually he or she is having a trouble, functional MRI could help. Okay, so functional MRI studies, okay, if somebody plans to do that in patient with long COVID, we can have a subset of patients, okay, where we can pinpointly identify that this particular area has been possibly under inflammation or some damage.
Thank you so much. This information is really useful, and I hope people will take this presentation and share with their practitioners for them to understand what can be the main cause for long COVID symptoms, because this is really important. We want to raise awareness of the up-to-date science that people like you and other scientists are doing, and we need to educate our practitioners so that they know the best solutions for long COVID sufferers. So thank you very much. And this is all for today, and goodbye.
Thank you very much. Bye-bye.